Asmita, let me know when we can start.
Sir, we can start the session.
Okay. Uh, Hello, everyone. Good evening. Welcome to another webinar by the Autoimmune Subsection of the Indian Academy of Neurology. Today, we have a very interesting case being presented by Dr. Gayatri Srikumar from Sri Chitra Tirunal Institute of Medical Sciences, Trivandrum. And the case will be moderated by Dr. Shruti Nair from Sri Chitra and Dr. Netravati from NIMHANS, Bangalore. So I hand over to Dr. Shruti to take over the proceedings. Thank you.
Thank you, Ayush. Very good evening to everyone, and thank you for IA and Autoimmune Subsection for giving us an opportunity to present this case. So, without wasting much time, I'll ask Dr. Gayatri Srikumar, our PDF, to start presenting the case. And as a change, we'll have something related to the peripheral system rather than central in this occasion.
Am I audible, ma'am?
Yes, please go on.
Good evening to one and all. At the outset, I'd like to thank the Indian Academy of Neurology, Autoimmune Subsection, and my professor, Dr. Shruti S. Nair, for giving me this opportunity to present in this prestigious platform. May I begin with the presentation, ma'am?
Gayatri, you'll on your video.
1 second, ma'am. It is showing it is switched on, ma'am. But even I'm not able to.
There is a problem in your camera, Gayatri. I can see here it detected issue in camera.
Okay.
Okay, never mind. You can start screen sharing and start presenting your case.
Right. Are my slides visible?
Not yet.
Okay.
They have not come yet. Yeah, good.
Visible, ma'am? Yeah.
Yes. Please go.
So I'll be presenting a case of recurrent sensory motor syndrome. So we have a 59-year-old gentleman who is an artist by profession. He paints the billboards, who initially presented to us in 1990 at the age of 30 with a rapidly progressive worsening, weakness and sensory symptoms along with dysphagia. He was bed-bound in 48 hours and he was diagnosed as Guillain-Barré syndrome at the point. He was treated with 10 cycles of plasmapheresis and he recovered to baseline. He was able to do all his activities of daily living following the same. 33 years later, in August 12, 2023, he had a sudden onset paresthesias in bilateral upper limbs followed by the soles in half an hour. He also experienced a sudden onset neck pain radiating to bilateral shoulders. The paresthesia was persistent throughout the day with no fluctuation in intensity. The next day morning at around 3 a.m., he started noticing that there was an unsteadiness of gait and buckling of knees. He was still capable of moving without any help. By around 8 a.m., the unsteadiness was progressing, for which he was taken to the nearby hospital. When he reached the hospital, he was able to climb down from the auto and get up with minimal support. He, at that time, realized that he was having difficulty in gripping his footwear and loosening of the footwear without awareness. There was difficulty in gripping objects with hands and buttoning and unbuttoning also. He was referred to a hospital for further evaluation at the point. He reached the hospital on the same day, but by the time he was brought in, he was wheelchair bound and he could not stand on his own. There was no history of cranial nerve involvement, no neck weakness noted, no Lermit signs, bowel and bladder complaints, wash basin phenomenon, no history of palpitation, excessive sweating or giddiness was noted, no recent history of vaccination, dog bite or fever, snake bite noted, no history of abdominal pain, vomiting or discolored urine was noticed as well. On examination, patient was conscious, oriented to time, place, and person. His vital signs were stable. There was no evidence of arrhythmias, no orthostatic hypotension noted at the point. No skin, nail, or hair abnormalities, no bite marks were noted. On systemic examination, there is no evidence of a paradoxical respiration also. Coming to neurological examination, his higher mental functions and cranial nerves were normal. The facial nerve was normal and no bulbar dysfunction was noted. On motor examination, the bulk and tone was normal. On examination of power, neck was normal. Proximal upper limb muscles were normal. However, there was weakness noted of the distal upper limb muscles, which was symmetric, predominantly involving the finger flexors and extensors and the small muscles of the hand. In the lower limb examination, there was weakness of proximal and distal muscles, which were symmetrical, with distal more than proximal involvement. Reflexes showed a global areflexia, and bilateral plantars were mute. On sensory examination, patient was having a pinprick loss, which is marked in red over here, up till the ankle in bilateral lower limb, and in both the hands up till the level of wrist symmetrically. The vibration loss was present, reduced symmetrically up till the level of tibial tuberosity, and in the upper limb up till the level of wrist. Joint position sense was impaired in both the feet up till the level of ankle and wrist in both the hands. Cerebellum, skull and spine examination was normal, and he had an ataxic gait. There was no peripheral nerve thickening noted. Autonomic system examination, which could be done, was normal. No signs of meningeal irritation as well. So summarizing the clinical history and examination findings, we have a 59-year-old gentleman who has a previous history of Guillain-Barré syndrome, from which he fully recovered, with acute onset, rapidly progressive paresthesias in all limbs, along with the neck pain, unsteadiness of gait, and quadriparesis. The examination showed symmetrical distal predominant lower motor neuron type of quadriparesis. There was a pan-sensory loss involving both the upper and lower limbs. Global areflexia was noted. There was no involvement of a cranial nerve, bulbar, or autonomic symptoms.
At this point, I have
Yes.
another question. Are you convinced that it is polyradicular neuropathy? You can go with your next slide and discuss that.
Yes, ma'am. So the clinical features have been so far consistent with the polyradicular neuropathy. However, there are some odd points with regards to a usual GBS presentation. One is that there is a prior history of GBS. Recurrent GBS is not a very common presentation. Second, there was an extremely rapid progression in this individual, very similar to the prior presentation he has had. Even with such rapid progression, we do not have a cranial nerve involvement or a bulbar involvement or autonomic system involvement. Also, in contrast to the normal presentation, there is a distal predominance that we have noted in this individual as well. However, considering all that, polyradicular neuropathy would be the most likely diagnosis at this point. May I proceed, ma'am?
No, I have just one more few more questions. Yeah,
Yes.
Naitra.
One thing, Gayatri, if you can just go as localization of all the symptoms, then just giving one localization. For example, you said that this symptom started with paresthesias, and then there was a neck pain, and then there was unsteadiness and buckling of knee.
Yes.
So if you are able to localize each of them, and then you can tell why you thought of polyradiculopathy, than just telling the typical and atypical points. It will be helpful for the students who are listening here.
Sure, ma'am. Sure.
Yeah.
Can I go back to the history slide? So initially there was a sudden onset paresthesia in this person, which was involving the upper limbs and the soles within a very short period of time, which is suggestive of a non-length dependent sensory symptom. This could be suggestive of a peripheral neuropathy, but since it is not a typical length dependent symptom, we could also consider the possibility of a radiculopathy over here. There is also a sudden onset neck pain which is present, which could suggest a pain, a lesion which is involving the region of the neck. It could be either one of the local structures. It could also be suggestive of a myelopathy, in which case it is usually a very dull aching sort of pain, or it could even be a radiculopathy. There is no characteristic features of the lancinating type of pain, which increases with Valsalva maneuver, which has been mentioned by the bystander so far. With this, patient also started developing unsteadiness of gait and buckling of knees.
So in your impression, what do you think the neck pain was? Because you did not give us more clarity on the neck pain.
Yes, ma'am.
The rest of the things, what you're talking about, the paresthesias and weakness, I understand. But the neck pain is something which is completely different to pinpoint towards a polyradiculopathy. So if you can just explain the neck pain and what is your impression about it?
Considering the entire picture, I'm thinking about a radicular pain as the most likely diagnosis over here, ma'am. But it could also be a local structural pain over there. The character, we did not have a lot of history regarding what was the character of the pain, which is described by the
that's okay. If you can just tell us what will be the history in case if it's a radical or if it is a peripheral nerve or if any other myelin. So if you can just try to distinguish or the local. These are the 4 reasons, right? Whenever you have a neck pain. So can you tell what are the characteristics of the neck pain based on all these 4?
Yes. In case of a local pain, which is a local mechanical structure which is getting involved, it is usually a localized pain present over there, which might be associated with tenderness. In case of a radicular pain, it is characteristically described as a lancinating pain, which is present or increased while the patient has performs any maneuver, Valsalva maneuver, like when he is coughing or while he is using the washroom. In case of a pain which is because of a tract involvement, it is usually a very dull aching pain.
And it is deep-seated. It is very difficult.
Yes, ma'am.
So strict localization. On the other hand, when you have radicular pain, it is the patient is usually able to draw and tell you the direction which the pain is going.
Right.
But if it is tract pain and even plexus pain, the patient will not be able to just tell you
Yes.
the exact localization. They usually show with their entire hand
Yes.
rather than one finger or a longer tract. Now,
Right.
is the radicular pain in a diffuse disease like a polyradiculopathy, is it different from the radicular pain of that structural lesion like a disc or anything? Because you were talking as that, would that be a similar thing?
Usually, in case of a radicular pain which is localized to a particular radicle, it will only be involving that particular region. It might also be associated with the other muscle weakness also, which is being innervated by the radicle.
Yeah, but pain alone, do you get that kind of pain in a diffuse disease like this?
In case of polyradiculoneuropathy, pain is a known symptom in around 20 to 30% of patients.
And what does it? What do you think the cause is? It is even more than that. Maybe some people tell around 2/3 may have that kind of problem.
Okay.
So what do you think the cause is?
It is the inflammation in the proximal nerve roots, ma'am.
Yeah. So it is inflammation of the radicals that causes the pain. Dr. Netra, do you want any more discussion?
And usually it will not be just one. When you have both upper limb and lower limb involvement just coming in the neck. And if possible, then using the word lancinating, shock-like sensations, or because lancinating will be for us, of course, but whether that was there, if you could have just brought about, it will be helpful.
Thank you, ma'am. Yes, ma'am. I'll take note of that.
Okay, you can go ahead.
Yes. The second symptom, along with that, he also presented with an unsteadiness of gait, which was suggestive of an ataxia, which could be a sensory ataxia or a cerebellar ataxia or a vestibular ataxia. Considering that the patient is having significant sensory symptoms, it is more likely to be a sensory ataxia. Initially, patient said, that is at around 3 a.m. in the morning, he said he did not have any features suggestive of a wash basin phenomenon, but then the unsteadiness was progressing and he was bound. So because of which we cannot take that history for the later progression of the disease. So considering that the sensory symptoms were also present, this is more likely a sensory ataxia that the patient is suffering from. The third symptom was the buckling of the knees. Buckling of the knees is usually because of the knee extensor weakness, and buckling of knees, which is presenting quite early in the disease course, is suggestive of a proximal more than distal and an element type of weakness. He also, later on, he started noticing difficulty in gripping his footwear and loosening of footwear without awareness. This is suggestive of a weakness in the distal muscles. At the same time, loosening of footwear without awareness could also suggest the sensory loss, which was noted in bilateral foot. The difficulty in gripping his footwear could also be attributed to the sensory loss. He also noticed that he was having difficulty in gripping objects with his hands, buttoning and unbuttoning. This could also be because of a weakness. It could also be because of the sensory loss that he's experiencing. He's not able to feel the buttons very well. So it is a very rapidly progressive illness by which he was wheelchair bound and he could not stand on his own by the time. So rapidly progressive symptoms. So considering the fact that there was a sudden onset, acute onset, progressive, sensory and motor involvement in a non-length dependent pattern, I would like to consider radiculopathy as the most likely diagnosis. The other possible diagnosis that we can consider at this point, if we are considering muscle and neuromuscular junction, should be excluded because there are prominent sensory symptoms which are present over here. Peripheral nerve, this is not following an exact pattern of a peripheral nerve involvement. Fourth would be a plexus. It is a symmetrical involvement of the upper and lower limbs, even though there is sensory motor involvement. So plexus seems like an unlikely diagnosis. Myelopathy can be a possibility, but considering the fact that even with such rapid progression of symptoms, there is no bowel and bladder involvement or a sensory level in this patient. That seems like an unlikely anatomical localization at this point.
Yeah, and plexus, it is generally a unilateral disease. At the best, especially lumbosacral plexopathy, you get bilaterality or asymmetric bilaterality. So anything which is rapidly affecting multiple limbs, you may not want to consider that possibility at all.
Okay.
No, please go ahead.
Yes. Shall I proceed with the rest of the case?
Yes, I think. Yes,
sorry.
Shruti.
So an examination, are you convinced it is a polyradicular neuropathy? What supports your diagnosis?
Such a global areflexia quite early in the disease course is quite suggestive of the same, along with the sensory motor syndrome.
So the areflexia kind of sorts it out for us. Sometimes bladder may be missed, not usually in this such severe situation.
Yes,
Some people may be catheterized early, or they may have, some retention without them realizing it. And we may need, it may come out later on. So the examination kind of clinches the fact that there is a peripheral involvement.
Right.
And you have no evidence at all of any central, like there is no level, there is no evidence of any spasticity or anything to say that it is a central problem going on.
Yes, ma'am. Yes. So this is just to brush up the 2023 guidelines of Guillain-Barré syndrome by European Academy of Neurology. So we consider the possibility when there is a progressive weakness of arms and legs, and when the tendon reflexes are absent or decreased in the affected limbs, and the progressive worsening lasting for less than 4 weeks. In our case, all of these criteria have been met. Along with that, the supporting diagnosis would be a relative symmetry. But unlike our case, other features that have been mentioned are mild or absent sensory signs and symptoms, cranial nerve involvement, autonomic dysfunction, respiratory insufficiency, pain, recent history of infection. All of these are also features that can support the diagnosis. There are certain findings which make the diagnosis of GBS unlikely, which is asymmetricity, very severe respiratory dysfunction with mild limb weakness, predominant sensory signs with mild weakness, fever, hyperreflexia, upper motor neuron involvement, bowel and bladder dysfunction, abdominal pain, vomiting, etc. None of these findings have been present in our case. This has already been discussed. This is just if the patient presents to us with a recurrent GBS-like presentation with predominantly a motor presentation, these could be the anatomical localization that we can consider. Like I've already mentioned, a polyradicular neuropathy is the first diagnosis localization that we can consider, in which case, other than a recurrent AIDP, we can consider acute onset CIDP, autoimmune nodopathy, vasculitic neuropathy, hematological malignancies, acute infection or HIV seroconversion, porphyrias, nutritional causes as well. Muscle and neuromuscular junction can be considered when it is a pure motor syndrome with channelopathy-like presentations having very similar features. Spinal cord can also present similarly if it's an acute transverse myelitis or a Morgard-related syndrome, but the absence of bladder and sensory level makes it unlikely in our case. And the higher CNS disorders like a stroke, rhombencephalitis can present with an acute onset quadriparesis. However, in our case, we do not have any brainstem signs or encephalopathy or any signs localizing to a central nervous system. Proceeding to the nerve.
Before you go to the investigations, Gayatri, so anything else you would want to see on the examination? Now, when you have a case of polyradiculopathy, polyradicular neuropathy, you spoke about few things,
Yes.
autonomic signs and many other things. Can you tell what are the relevant general physical examination? It may not be relevant to your case, but whenever you have a polyradiculopathy, what are the general physical examination which you need to stretch?
Initially, we would want to look at the vital signs to rule out the possibility of an autonomic involvement being there.
Okay.
Since polyradicular neuropathies are also known to occur with heavy metal poisoning, it is important to look for other associated signs like alopecia, Mees lines. In case of lead poisoning, we can look for the Burtonian line, which is the blue line seen over the gums. We could also look for peripheral nerve thickening in the general system examination. Yeah, that is what I can think of, ma'am.
Do you get papilledema in any case of polyradiculopathy?
It has been described in Guillain-Barré syndrome, ma'am.
Why it happens? Dr. Shruti spoke about urinary retention. The same thing happens even with the papilledema also. So whenever you have a albuminocytological dissociation, the high protein,
Yes.
and because of the nerve involvement, you can have a papilledema. And sometimes if it is a chronic, not in this case, acute, this was a hyperacute presentation, but you have a hyperacute, you have a subacute to chronic, and you have some other hyperpigmentation in the skin and organomegaly, then you should also think of Poem syndrome. So papilledema will come in such cases to know about the eye findings. Any other findings? You spoke about nail, you spoke about hair. Then we discussed on the eye. Anything else? It may not be relevant to this. I'm just telling you polyradicular neuropathy. What are the general physical examination findings?
If we might want to look at skin lesions for vasculitis, madam.
Okay. So same thing, hyperpigmentation can be there in Poem syndrome. You can have vasculitic lesions. Will you also look for hypoaesthetic patches in this because it's a polyradicular neuropathy, or only when it is a peripheral nerve you will look for it?
I'm sorry, madam, I didn't catch the question.
Skin hypoaesthetic patches. This was a very hyperacute presentation, no?
Yes, ma'am.
So when it is a hyperacute presentation, even for hypoaesthetic patches also, you will have to look for. If it was areflexia will not come with Hansen's and other polyradical, but because it was a hyperacute presentation, because of what are the phenomenon which happens in Hansen's for you to suspect a radical along with peripheral nerve? Are you aware?
No, ma'am.
What are the reactions which happen in Hansen's?
The type 1 and the type 2 reactions, madam. You should be. Oh, yes.
So sometimes then also you can get all these so you'll have to look for hypoaesthetic patches because you have a hyperacute presentation.
Okay, ma'am. Okay.
Okay. Organomegaly?
Organomegaly, yes, in order to keep the possibility of poems also.
Not in 59-year-old, your case is a 59-year-old, but if it was a young child who had come with a polyradicular neuropathy, you spoke about one of the differentials as porphyria.
Yes.
So in such cases, what else will you look for?
We could elicit the history of abdominal pain, vomiting, neuropsychiatric features, urine discoloration.
Urine discoloration, that will be the most important thing for you to ask for this one. Okay, which heavy metal are you suspecting?
Lead can present with a pure motor presentation. Thallium and arsenic has also been known to present with polyradiculopathy-like presentation.
And when it is lead, which is the type of limb and what is the type of presentation? You said one is motor.
Yes.
And then what is the other one?
It can present with a wrist drop.
Usually it is in the upper limb, so it's usually comes because it affects the radial nerve usually. So it happens with a wrist drop. It doesn't come with, most of the time it is, they'll also have nail changes. So in your negative history, you'll have to ask about occupation also
Right.
when you're taking the history. You asked about many other things, even the occupation has to be taken.
Yes.
Okay, okay. You want to ask anything else, Shruti?
No, no, well analyzed. The other concern, suppose this patient had intact reflexes. How would your thoughts change? Like the sensory is less and or absent and the reflexes are very much present, but the rest of the findings are pretty much the same.
At that point, I would like to also consider the possibility of myopathies, ma'am.
Yeah.
Is
there any variant of GBS itself that can have that presentation?
The axonal variants?
Yes, especially Amman is known to have a brisk reflex. So you sometimes your potassium or your CPK may be the only clues to help you differentiate.
Okay.
And of course, here you have a distal more than proximal. It's not always very useful when you are dealing with an acute case, this limb-girdle phenotype. But yeah, if you have a distal more, and even if the reflex are towards the breast side, you may want to consider the possibility of a Amman variant.
Right, right. Shall I proceed?
Yeah.
Coming to the the nerve conduction study. In the motor conduction study, the parameters in bilateral median nerve at the wrist level, the distal latencies are in primary demyelinating range. There is also a conduction block which is noted in the right ulnar nerve. The conduction velocities in the lower limb are reduced, but they are not in primary demyelinating range. Coming to the F waves, there is a prolongation of F waves from bilateral upper limb. Sensory nerve action potentials are absent from upper limb. They are reduced from bilateral sural and right superficial peroneal nerve. So there is a sural sparing pattern which is noted over here. So there is evidence for a diffuse, symmetric, demyelinating sensory motor polyneuropathy as per the nerve conduction study.
When do you say conduction block? Which criteria are you talking about?
Conduction block, we use the AIDP criteria by Rajvalli. And for the CIDP, we use the EAN criteria, madam, 2021 criteria, which mentions it as 50%. We can also take it as 30%, but the settings in which the study is being done has to be a little more stricter.
When do you say that there is a prolonged distal latency?
Prolonged distal latency is considered to be, as per Rajavali's criteria, it is more than 150% of the upper limit of normal. In our lab, the median latencies is 3.8. So more than 150% would be 5.7. And sorry, in the ulnar, it would be 4.5. The 3 would be the cutoff value. For 150% would be 4.5, ma'am. So here median bilaterally is prolonged.
So criteria you may want to use will depend upon many things. If you use Haddon's criteria, which is 110%,
yes,
you can diagnose it. It is far more sensitive, but you want to use that in younger people where you are relatively sure that you are unlikely to overdiagnose it. So I think Rajavalli is safer, but you may miss a few of the primary demyelinating, at least in the initial NCS that we see. Yeah, and conduction blocks. Yeah, I think it is it is highly dependent upon what your lab can do. If it is a pristine lab, you can definitely use the 20%, 30% criteria. In general, if it is done, we are not entirely monitoring it. It is safer to keep a 50% cutoff, where it is far less likely to be, a technical problem. And which nerves would you be really worried about, or which sites would you be worried about if it is 50% and it may not be relevant?
A tibial nerve is a site where we consider more than 50% as the criteria?
Yeah, 60% is there in some criteria, but as per the latest CIDP criteria, if you have conduction block in TBL alone, you may not want to take it as a conduction block.
Okay.
And another site would be Erb's point. If there is conduction block only across Erb's point, and the technician feels that this was a difficult test to be done, it may not want to take it as a conduction block.
Okay. Okay.
Of course, it may vary from case to case.
Okay. In the rest of the workup was showing a total count of around 12,900. Potassium in this case was 3.9. The rest of the complete hemogram was normal. CRP was elevated 88. Patient was also having a urinary tract infection during the course of hospital stay. CPK was 205. CSF study was done, which showed a total count of 3 cells. It was 100% lymphocytes. Protein showed 53.2, and there was evidence for albuminocytological dissociation. The CSF culture and the blood culture were negative. Urine culture later on grew Acitrobacter poceri. Because this was a recurrent episode of GBS, we also sent the secondary workup. The ganglioside panel was negative. The vasculitic workup was also negative. Urine porphyrin was sent, which was also negative. This was an MRI taken. It was showing a leptomeningeal enhancement along the conus medullaris, also with nerve root enhancement from D2 to L1, likely representing features suggestive of a demyelinating polyneuropathy. There was also a suggestion to rule out infective causes. CSF was done, which was normal.
So usually when you're suspecting a polyradicular neuropathy, this sequence, what you have put is more for a spine, and when you're having an arachnoid and the root, the proximal root, especially for arachnoid, it is for an infective. Otherwise, when it is a polyradiculopathy, you'll have to have a sagittal sequence with the plexus and the roots. That would be more important, which will give you a clue about the demyelination, which will show thickening and even the enhancement also in those cases.
Okay, ma'am. Okay.
You can proceed.
So in the course in the hospital, clinically, electrophysiological evidence, everything was suggestive of an...
So Gayatri, before you go to this,
Yes,
so your diagnosis at this time point is a recurrent GBS.
yes, ma'am.
Okay. Can you tell something on recurrent GBS before you go further?
Sure. Recurrent GBS is not a very common diagnosis. It has been noted to occur in about 2 to 5% of patients. Hello?
Yes,
in-
yes.
In patients who are presenting with recurrent GBS, it has been noted that it is more commonly seen in patients who've had their first episode at a much younger age group, which is in some studies mentioned as less than 30 years. It is also more commonly noted in the demyelinating variant more than the axonal variant. There is not very clear evidence as to whether any preceding events also cause the recurrence. In some patients, it has been shown to be the same preceding events which occur before every attack of GBS. However, in some patients, it has been shown that it is different preceding events. So there is no consensus regarding the same. When we do see episodes of recurrent GBS, we should consider other metabolic as well as certain genetic causes and immune-mediated causes as well, which can present in a very similar manner.
How much percent of CIDP can present as recurrent GBS?
16%, ma'am.
Yeah, so that also will be in your high, no?
Yes,
Your recurrent GBS is just 2 to 5%, but a GBS presentation in a CIDP case, especially when it is recurrent, is slightly higher. So that also should be in your differentials. Any other differentials you will keep apart from recurrent GBS, and if it is going to be a CIDP, any other possibility?
Especially considering the flavor these days, something that everybody loves to talk about.
Autoimmune nodopathies.
Yeah. I think now that is the nodopathies and paranodopathies and everything, no?
Yes.
These are the things which we need to consider now.
Yes.
Mhm. So will you be at this time point, before we come to know further, anything else in the history where we can try to differentiate between, or the examination, try to differentiate between any of these things?
To differentiate between CIDP as well as a recurrent GBS.
Or a nodopathy?
Sorry, ma'am?
Nodopathy.
Nodopathies also. Nodopathies, the ones that are known to present with such fulminant presentation is the pan-neurophysin antibody disease. And usually they are known to be associated with a very rapid progression with severe autonomic as well as cranial nerve involvement. It has been known to cause death if there is not an untimely, there is not a timely intervention. The other one that has been known to present like GBS is the contactin 1, which is also associated with a nephrotic syndrome. So we could also look for evidence for same. Comparing.
Dr. Gayatri, I'm very glad you said that, because now, because testing is costly, it takes time, patients sometimes may not afford. For every patient with GBS who comes to us, I make it a point to look at the urine routine, because if you find even microalbuminuria, you should strongly start suspecting a paranodopathy, because unlike CIDP and GBS, it's not something that is seen otherwise. So because then you'll have to give rituximab early. So that is something that can be done very easily, does not cost much. So urine routine in a patient of GBS is, I think, a low yield or high yield investigation which gets missed because of the simple nature of the test.
Right, sir. Right, sir.
And unlike neurophysin, we do not have testing for contact in India. So that is definitely not going to be picked up in the routine.
Please continue.
Yes. A course in the hospital. A patient was admitted to the ICU and is even initiated on the plasma exchange. Hospital stay was uneventful. Following the plasma exchange, he regained his power of about 5/5 in his upper limbs and almost 4+/5 in the lower limbs. At the time of discharge, patient had mild lower limb weakness and was ambulant. So at this point, we had kept our final diagnosis as a recurrent acute demyelinating polyradiculoneuropathy.
Gayatri, did you mention about HIV in this patient?
In the initial investigation, no, madam, but it was tested. I've forgotten to add it, but it's mentioned in the subsequent evaluation.
Okay, so it was negative?
It was negative. It was negative. All the viral markers were negative.
Okay.
Shall I proceed, ma'am?
Yeah.
So patient was on regular follow-up with us and he steadily improved. He had difficulty in getting up from sitting position, minimal, and he needed a support. He also had minimal difficulty in climbing up the stairs and needed to hold on to his rails once in a while. But other than that, he was still able to walk almost as long as 3 kilometers without any support, and his sensory symptoms and upper limb symptoms had completely resolved. We had taken a repeat in nerve conduction study in this individual about 1 year after his first attack. And as we can see over here, in the bilateral median nerve, the latencies which were initially in the primary demyelinating range has come down. It has still not reached the normalcy, but it has definitely reduced. The conduction block, which was present in the right ulnar nerve, is currently no longer present. The F waves, which still continue to be prolonged. However, the sensory nerve action potential was previously absent from bilateral upper limb. It is currently present. However, the sural nerves did continue to show reduction. Patient came back on 28 November 2024 with a sudden onset paresthesia, which is ascended up till his knee and palms over 1 week. Again, he had difficulty in getting up from the floor and climbing stairs, which had progressed, difficulty in mixing his food, with no proximal upper limb weakness. There was no history of cranial nerve, bulbar autonomic symptoms, no orthopnea. On examination, the examination findings were very similar to the prior event. Higher mental functions and cranial nerves were normal, with the neck and proximal upper limbs having normal power. Wrist flexion, extension, small muscles of the hand were weak. Lower limb, proximal and distal weakness of 4/5 were noted. Last time, the distal weakness in the lower limb was a little more predominant. However, this time it was more or less the same. Patient also had global areflexia and the plantars were mute. Sensory system examination showed graded sensory loss up till the level of bilateral knee. Both vibration and pinprick was reduced. JPS was impaired in toes. In the hand, the vibration and pinprick was lost up till the level of wrist. Cerebellum was normal.
What was the interval between these two episodes?
Sorry, ma'am?
What was the interval between the episodes? The first one was in 1990. And
First
then
episode 1990.
August 23, then this is November 24.
Then 24.
yes.
13
First-
months.
First two episodes were 33 years apart, then 13 months.
He was the artist, no? Painter.
Yes, ma'am. He's a billboard painter.
Okay.
He did give history that he was having an exposure to some metal fumes occasionally. So we had requested for a heavy metal screening for him, but due to financial constraints, they did not want to proceed with it.
So that was not done in the first time also, right?
No, it was not.
But lead levels, it's not that costly, I think. It's just 250, less than 500 rupees. We didn't do lead levels also.
No, ma'am. It was not done at that time.
Okay.
We do it as a panel in DDRCs. This is done in-house, this lead panel?
No, we send it to the neurochemistry. So not here, sometimes in another hospital, but they do it for a lesser rate. It's done quite because lead poisoning is something which is occupational, and a few many we have found, but the cost is very less. It's less than 500 rupees. I've done it multiple times and we have got it positive. Because this was a recurrent symptom and because he was a painter. So I think lead is one thing which we need to consider.
Absolutely, because we have a panel which we sent to a private lab and that costs quite a lot. I did not know that this was available cheaply. Yeah.
Mhm.
Thank you.
Proceed, guys.
Yes. So the nerve conduction was repeated again, and at this time, the distal motor latencies in both upper limbs, both median and ulnar, were in primary demyelinating range. Even in the lower limb, in the right peroneal and the right tibial nerve, the distal latencies were prolonged. The CMAPs were reduced from bilateral lower limbs. There was no evidence of a conduction block at this time. All the FAF latencies were prolonged. Sensory was showing reduction absence in the left median nerve and a reduction in bilateral lower limb. There was asymmetry noted between the bilateral superficial peroneal nerve. So this was a diffuse, fairly symmetrical sensory motor demyelinating polyneuropathy.
Could I just ask this for any students who are listening?
Yes.
Why do you call this demyelinating? Why is this not axonal as well? Because we have shown the reduced CMAP amplitudes from the lower limb nerves.
Yes. When we usually consider, there are particular values above or below which we consider the disease activity primarily to be because of demyelinating. So when we take these values, the distal latencies would be about 150% of the upper limit of normal. In case of conduction, in case of analyzing the CMAPs, between the proximal and distal, if there is a 50% reduction, it is considered to be a conduction block, and that is again suggestive of a demyelinating neuropathy. Mostly, there is also an entity of a reversible conduction failure, but for general discussion, it is considered to be less than 50%. Conduction velocities of less than 70% is also considered as primarily demyelinating. So even when we have axonal loss, there will be loss of myelin because a certain number of axons which has the myelin is also reduced, which will lead to definite reduction in the conduction velocity and prolongation of distal latency. But by adhering to these stricter cutoffs, we are able to differentiate between demyelinating as well as axonal variants.
So if you have parameters in the primary demyelinating range in 2 or more nerves,
yes,
that should be a primary demyelinating disease. That is the entire concept of it. Unless there is some other etiology you can prove, like an entrapment neuropathy.
right.
Right. And then why do you see the reduced CMAPs? If you can go back once. What is the explanation for the reduced CMAPs?
The demyelination by itself can also reduce the CMAPs.
How is it? So you don't require an additional axonal process to cause it. If you have a distal conduction block, which is distal to a site of stimulation,
Yes, ma'am.
that is sufficient to cause a reduced semen. So that so the differentiation is only possible maybe by EMG, whether it's a secondary axonal loss or whether it is a primary demyelination with the distal conduction block.
Right.
So the essence is that if you have any two nerves which are showing demyelination in the primary demyelination, that straight away becomes a demyelinating polyneuropathy. Okay, so please go on. So there is a definite worsening now.
Yes, ma'am. So
Gayatri, we were just asking if in the differentials we think of lead or a toxin mediate neuropathy, what are the conduction you see in that versus recurrent GBS?
if you're taking the idea, it will be more likely involvement of a single nerve rather than a diffuse process that we see in here. Here, we would be expecting a conduction block in, because it presents with a wrist drop, we can look at it in the radial nerve.
So usually it is an axonal pattern. Here, predominantly it's a demyelinating.
Yes.
So that is also one thing. Sometimes you may not get, usually upper limb radial, but if it is heavy or a heavy metal, and sometimes heavy metals can be mixed with many other things, they are more of axonal. Here, both the times you got demyelination. So that is a way to differentiate between those things. Any other infective causes we need to consider?
HIV is known to
HIV,
be
and then does Lyme's cause like this?
Yes, ma'am.
Okay, how we can differentiate clinically, investigations, conductions, and clinically?
Antibodies, Lyme's.
No, before we get the antibodies, anything on clinical and investigations you can differentiate between Lyme's and this?
The lesions which are noted in the skin in case of Lyme's, ma'am.
Some skin lesions, endemic areas.
Yes.
Endemic areas. And what about the conductions in Lyme's?
I would need to refer back on that, ma'am. I'm not sure.
I'm not sure. Shruti should tell us. I'm also not aware.
I also don't know. I know that there is a higher propensity for facial involvement to be there.
Yeah, even I'm not aware.
Yeah, it is preceded by fever and that serpiginous rash that you have. Conduction wise, I really do not know.
Ayush, you know? Okay, go ahead, guys.
So until now, we had considered the possibility of a Guillain-Barré syndrome. So I think the next few slides we have already discussed. However, so usually it is a monophasic disease. So when you have a recurrent GBS, it is quite rare and only seen in about 2 to 5% of patients. When we have these recurrences in association with GBS, we do consider certain clinical entities. The first one is treatment-related fluctuations. So treatment-related fluctuation is when the person who has been diagnosed with GBS has an improvement in the disability scale of at least 1 grade or an MRC sum score of at least more than 5 after completion of therapy. Or if there is no improvement in the scale, at least if the patient has been stable for a period of 1 week, and within a period of first 2 months, if there has been again a worsening, then it is considered to be a treatment-related fluctuations. In GBS, we do expect up until 2 treatment-related fluctuations are considered acceptable under GBS. But if we have 3 or more treatment-related fluctuations, we will have to start considering the possibility of an acute onset CIDP. The second is recurrent GBS itself. When we have the presence of at least 2 GBS episodes, which has reached its nadir within 4 weeks, and the worsening happens after at least 2 months. If the patient has actually completely recovered, if the worsening happens after 2 months, and if there is some sort of a residual disability, if the worsening happens after 4 months, this can be considered under recurrent GBS. The rest of the points have already been discussed. So the duration between the recurrent GBS has been quite varied. It can be as short as 2 months to almost one of the longest case reports that I saw was up till 43 years. In our case also, between the first and second episode, it was 33 years. It could also be a part of combined central and peripheral demyelination syndrome. Coming to acute onset CIDP, acute onset CIDP is noted in 5% of patients with GBS, and nearly about 16% of patients who present with CIDP may have an acute onset CIDP initiation. So in a patient who has CIDP, in whom the nadir of the first episode occurs within 8 weeks of onset, and then the subsequent course might be chronic. As I already said, if there is more than 3 treatment-related fluctuation in a single episode of GBS, we might want to consider the possibility of CIDP. To differentiate between CIDP and recurrent GBS is a slightly tedious task. However, it has been certain clinical points have been noted. Acute CIDP is more commonly noted in patients who are of older age. Second, they will have more marked sensory symptoms, including sensory ataxia. In these patients, there might be facial, bulbar, or respiratory weakness might not be a very common presentation. They might have a slower disease progression. Ultrasound might show widespread peripheral nerve enlargement, and motor nerve conduction velocity might be reduced. In case of a differential diagnosis of recurrent GBS other than GBS, we can consider immune-mediated conditions like CIDP, autoimmune nodopathies and vasculitis, metabolic conditions like porphyry and heavy metal poisoning. Genetic conditions, in case of a pure motor variant, you can think about channelopathies, congenital myasthenic syndromes, riboflavinopathies, and certain genetic conditions like refsums, RCC1 mutation, CD59 mutations, and some genetic tubulopathies also. So at this point, we have a 68.
I'll interrupt you for a moment. Which riboflavinopathy are you talking about?
The Brown-Violetto-Vanlier syndrome, ma'am.
Yeah, so in children, it has been reported as case series as well, that they can present with recurrent episodes of what looks like GBS. And the NCS is often axonal rather than demyelinating in these children.
Yes.
But
And
aren't they also cranial and bulbar? Facial and bulbar?
So they may present as head rope, or they may present as a pharyngocervical variant as a presentation. So we have also had one child who presented like that and got quite a lot of immunotherapy before the diagnosis was made. In fact, the clue was there straight away because SNHL was there in the background. The child had sensorineural hearing loss. Everything had been put, the cochlear implant, everything was already in place for the child. So what about the other conditions like CD59 and RCC1? These are new entities.
CD59 mutations are usually noted again in children, and both RCC1 and CD59 are autosomal recessive diseases, which are predominantly noted in the pediatric population. So CD59 is basically it is a component which is present on all cells, and the primary action is to make sure that the complement activation is not too much. So it basically keeps the complement activation under check. So when children have viral or a bacterial infection, minor illnesses, the complement action in patients who have CD59 deficiency, the complement activity is quite uncontrolled, and this leads to sudden onset presentations resembling GBS. In case of CD59 mutations, it has been mentioned as very similar to demyelinating neuropathies in the electrophysiology. But in case of RCC1 mutations, it has been noted as an axonal neuropathy. Again, it is also an autosomal recessive condition which has been noted in children. And in RCC1 mutation also, optic neuropathies are usually optic neuropathies, and I'm not very sure about the hearing loss, but that could also be associated. I will have to check on the hearing loss, ma'am.
So I think CD59 has been reported from India. The main thing is that they respond to IVIG, but often partially. But the actual therapy would be eculizumab because the complement-mediated damage is the primary driving force there.
Yes, ma'am. The genetic tubulopathies, which they mentioned, is also primarily acting against the renal tubular cells, the solute carrier proteins, and that leads to a lot of potassium loss. So it presents like sudden onset hypokalemic periodic paralysis, hypokalemic weakness. Should I proceed, ma'am?
Yeah.
So at this point, we have a 60-year-old gentleman with a recurrent AIDP-like presentation. He has a distal predominant sensory motor syndrome, significant sensory ataxia with no cranial nerve, bulbar, or autonomic symptom. So with this, our working diagnosis was a recurrent GBS versus CIDP. Looking into the criteria for CIDP as well.
I think, Gayatri, will just proceed a bit faster now.
Yes, ma'am. Yes, ma'am. So, looking at the EAN 2021 criteria, it fits into a typical CIDP pattern. However, the distal predominance would want us to pay attention to the distal CIDP criteria variant as well. So we again did the investigations in this gentleman. The potassium was again 4.3. CSF showed only 3 cells with 100% lymphocytes, exactly like the previous study. Again, he had elevated 79 protein, which showed an albuminocytological dissociation. The secondary workups were negative. The HIV, HPSAG, hepatitis C was also negative. Again, we had done the urine porphyrins, which were negative.
NMO MOG is required in this case.
Madam, NMO MOG was primarily sent because in the MRI that was done, even initially, they mentioned that there was leptomeningeal enhancement, which is present predominantly around the conus medullaris region, because of which it was sent. That's all, ma'am. We also sent the ganglioside antibody panel, which was negative. Serum protein electrophoresis with immunofixation was performed, which was negative. The free light chain assay was showing mild elevation in free kappa, but the ratio was normal. We had sent the anti-ganglioside MAG antibody, which came to be positive, 55.85%. We were using an ELISA in our lab, and it came out to be positive. Neurofesin antibody panel was also sent, and NF140 had come out to be positive with a cutoff of 475. The MRI, which was performed, was showing stir hyperintensities in bilateral lumbar nerve roots along with the contrast enhancement. Even in the brachial plexus, there were a nerve root enhancement, which were noted along with stir hyperintensities. So when we look at the CIDP criteria, EAN 2021, it has been advised to do the MAG antibodies in all the patients who are suspected to be having a CIDP, especially a distal CIDP, if they have an IgM paraproteinemia. And it is advised that we look at either the Bullman's titer, which is the ELISA, which was standardized by the Bullman's laboratory, or we can look at the locally validated ELISA, which was like what was done in our lab, or Western blot or immunohistochemistry assays.
So now we have actually 2 candidates for your recurrent AIDP presentation. No? One is that MAG antibody is positive. Another side, you have a neurofesin 140 positive. So how do you
tease that out?
Yeah.
To actually say that the MAG antibody is relevant, it is recommended that we have to confirm it with another confirmation assay, like the Bullman's titer. So technically, even in the guidelines, it has been said that a very high titer is the only thing that is a high titer, as in when it is more than 1,500, it has about 95% sensitivity. And if the titer is more than 7,000, it has almost 100% sensitivity. Some of the recent studies have mentioned that we need at least more than 10,000 Bullman titer to actually call it as a MAG neuropathy.
Right. But let's go clinically from what we have.
Yes.
Do you think the clinical picture fits?
In a normal distal CIDP, or a typical, not normal, typical distal CIDP usually has more of sensory symptoms. It has a more slow chronic progression of symptoms rather than this sudden onset progressive proximal motor also associated weakness. So that is slightly atypical for a distal CIDP. And a MAG.
Is that all? Do you need any? Are there any reports of any acute GBS presentations with MAG?
Proximal CIDP like presentations have been seen, but I'm not aware of an acute GBS presentation that has been noted with MAG.
There are.
Sorry,
yeah. Please, Dr. Ayush.
No, I was just asking that MAG antibodies are usually not available very easily for testing and are costly, at least in the place where I work. Yes. So our thought is that if we have a DADS-like phenotype, at least if the electrophoresis and immunofixation shows up an IgM band, then we start to ask the patient if they can afford sending anti-MAG antibodies. It's not something that we usually send in all CIDP-like presentations. So yes. Did you have something on electrophoresis or immunofixation that made you send anti-MAG?
This was predominantly sent because he was having a distal predominant presentation, sir. But like you said, it is also recommended that we are supposed to be sending IgM MAG after the serum protein if there is an IgM paraproteinemia, but we didn't have any of those, no.
Okay, so was it negative or was it not done because of financial constraints?
No. It was negative. It was negative.
negative.
Both
Correct.
protein electrophorese and immunofixation was negative.
So
So
because
our
of-
testing is skewed by the availability in-house or not. If it is available in-house, it is free to them. If it is to be sent outside, it becomes costly. That is what actually kind of
true.
skews the kind of
One second,
test that is sent. Yeah, so IgM was negative, no? IgM paraproteinemia was not there.
No.
Okay, Dr. Gayatri, because of paucity of time, please continue.
Yes. So again, if we want to consider, as per the guidelines, nodal antibodies also have to be sent. If you have a good lab setup which can support, which is meeting the quality standards. Also, it is advised in patients who are having a resistant to standard therapy with IVIG corticosteroids. If the disease onset is very aggressive with the prior history of GBS or acute onset CIDP, if there is a low frequency tremor or an ataxia which is disproportionate to the sensory involvement or cerebellar findings, respiratory failure, cranial nerve involvement, and an associated nephrotic syndrome, or very high CSF proteins. These are places where it is recommended to check for nodal and paranodal antibodies as well. Can I speak for a few slides on MAG neuropathy as well? Do we have the time, sir?
I think we should skip because at the end there are some questions that have already started to come up. So we'll have to take those as well before we wrap up.
Right. Sir,
Yeah.
right. So
rather than go through this, you can tell me, what do you think this is? Do you think this is MAG neuropathy? Do you think this is neurophysin 140 associated disease, or do you think it is something else entirely?
so, ma'am, this does not really typically fit into the clinical presentation of an anti-MAG neuropathy. That is, it usually presents with the paresthesias in distal lower limbs, and it is predominantly sensory, very slowly progressive. So it definitely doesn't fit into the clinical picture. Second is that it is quite odd that we do not have a paraprotein, IgM paraprotein, associated with the MAG neuropathy. Now, that is an entity that about 2 to 6% of patients can have MAG neuropathy without an associated IgM paraprotein. However, it has been shown that when you keep on doing the test serially, these antibodies, these IgM paraproteins do come up in the serial testing. So it might be initially that it was very minuscule, that we had not picked it up.
And what is the importance of having the diagnosis, whether it is MAG neuropathy or not?
It is important because the way we manage it is quite different. It is no longer considered as a part of the CIDP
Spectrum.
spectrum, yes, spectrum as per the current guidelines. Moreover, in MAG neuropathy, the conventional treatment of IVIG has not been found to be very effective. Even it has been recommended to continue with rituximab, but even that has limited evidence.
True. So even with rituximab, around 20% may have some benefit. I'm sorry, Ayush.
No, ma'am, thank you. There's a question by Dr. Pooja Anand exactly on that, and I'm glad we reached that point because she's asked that if somebody with anti-MAG neuropathy is not responsive to rituximab, how would you then proceed with regards to managing this patient?
So the other thing we could try, of course, is plasma exchange. That has the highest evidence. So repeated plasma exchange comes with a lot of issues. Then yeah, you have that. Yeah.
Yes. So the conventional treatment that we have is the IVIG, which is very decreased responsiveness, but rituximab is considered. Even rituximab is only responsive to 30 to 50%. So like ma'am said, plasma exchange could be used. It has been shown to be effective in certain studies. However, in the blinded and open label trials, it has not been shown to be very effective. Oral cyclophosphamide and prednisolone has been shown to have significant benefit in certain studies, but the primary endpoints were never met. Right now, there is also studies going on about the Bruton tyrosine kinase inhibitors, which is currently undergoing the trial. So I think Thermogap, I think that is the trial name. So that is also currently underway.
Shruti, just two doubts to consider anti-MAG. One is the acute presentation and the conduction block. Do we get such conduction blocks in anti-MAG and that acute presentation?
So the typical,
yeah.
So the typical presentation would be the prolonged distal latencies. without much of conduction block. So it
Mm.
is a predominant distal disease rather than an intermediate segment disease. But I don't think it will completely take away from the diagnosis of MAG neuropathy. Acute presentation would be considered extremely odd. Many patients have an underlying neuropathy with an acute worsening. In this element, particularly since this has been, something has happened with 33 years of latency, so it is very unlikely that at least the first episode had anything to do with the MAG neuropathy.
Right,
So,
right.
so what about Neurophasin 140?
Neurophasin 140, Neurophasin 140 is not an antibody which is found to be biologically present in an adult patient. It is commonly found when the person is in its fetal or the embryonic form. So the counterpart of 140 has been 186, which is present in the nodal region. But so isolated 140 being associated with GBS, there has been a recent publication, I think, from Kerala. But other than that, there are lots of caveats to consider that isolated NF140 can lead to this presentation, ma'am.
So the isolated NF140 positivity is not a documented disease because 186 has all the epitopes of 140. So anybody who has a 140 positivity should also have a 186 positivity. So we are not sure what the isolated 140 really means. It could also be part of a pan-neurophasin disease, which of course can present as acute GBS, like acute presentations of GBS. So, so this is, I think that autoimmune nodopathy better fits that profile.
Yes.
However, that 140 is a suspicious antibody to have.
Right.
So, panel, what do you think about it? Netra Madam, Ayush?
Ma'am.
Mine only concern was about the presentation in MAG. So whether we need to dissociate, that was the only thing which I already asked you. Other than that, nothing.
Yeah, so this is.
So
I would take NF140 positivity with a pinch of salt, considering it's always
Yes.
considered to be an infantile one. So if it is isolated positive, I would consider it fallacious unless there is something extremely important to show. And most commercial labs in India are doing ELISA, which is not the method to test it by, it's not a confirmatory test and cell-based assay. I think NIMS Hyderabad is one of the only centers that's doing it. So that we can send a sample there for confirmation.
even this is actually not our patients, sir, but I was just putting up the slide just to show that we were doing it with the ELISA only.
ELISA, yeah. So most centers, even we are doing it with an ELISA. So false positive rate is much higher. So NF140 by ELISA is something that I would ignore in this clinical context.
Absolutely. I think there's an article mentioning the same thing, that it should be taken with extreme care, particularly when patients have been given IVIG. But even without that, if you have NF140 positivity,
Yes.
isolated, it may not have much of a meaning.
Absolutely. Okay. Last 2 minutes, please.
Yes.
Otherwise, IAN would be after me saying that we overshot our 1 hour. It's rare.
Are there any
but
questions pending here?
Great discussions going on here.
Shall I wind up, sir?
Yeah, please wind up.
So the clinical course of this patient was that during this admission, patient had been given IV methylprednisolone for a course of 5 days, followed by oral steroids. He is currently on a long-term immunomodulation with rituximab since the past 2 years, and he has been doing very well. He has not had any further relapse. He is able to do his activities. So at this point, we consider it to be a CIDP, a chronic immune-mediated polyneuropathy. Anti-MAG neuropathy, like has already been discussed, might not be the likely diagnosis over here. So when we do take-home messages would be, when we do consider the possibility of a recurrent GBS, we have to look extensively to look for any other possible treatable entities like an autoimmune nodopathy. Antibody values should always be interpreted in the appropriate clinical context, and diagnosis should be ascertained with the appropriate clinical test and its confirmatory tests. Thank you.
Great presentation, Gayatri. I'll add one more point before Ayush kicks me out. Just one thing, we had 2 antibodies positive in this patient. Both of them may not be causative. The only thing is that because MAC has other connotations, it is important to follow up the patient for an IgM, monoclonal gammopathy developing later on. And then rest of it, it is better to go by clinical as of now.
Yes.
Ma'am, how commonly, that's just a question that I have, how commonly do you perform a skeletal survey of patients presenting with a slightly atypical CIDP? Because sometimes we find a skeletal survey give a hint of some sclerotic or a lytic lesion somewhere. So is it something that you do routinely for all CIDP-like presentations to you, or is there a specific subtype where you do that?
We send electrophoresis and immunoelectrophoresis, free light chain for almost all the patients. And then
Ma'am, skeletal survey, ma'am. X-ray.
then only if that comes positive do we go for a skeletal survey.
Correct.
So you have seen otherwise? Have you seen lytic lesions without?
I mean, we had recently last month, we had a patient who was classical poems, had all the skin lesions, had organomegaly also, had endocrinopathy also, because he gave us a history that he had some infertility, but his electrophoresis and immunofixation was negative. When we did an X-ray, we found that there was an osteolytic lesion in his skull, which we then biopsied and found and could diagnose poems. But he had other findings which were atypical for CIDP. So we started now to do it for all patients who do not fill the forme fruste of CIDP. Shripat sir is here. Sir, any final comments before Asmita decides to lock us up?
No, I think it is very excellent presentation, excellent discussion. Very nice. Many points to discuss. Good.
Thank you, Dr. Gayatri, for the presentation. Thank you, Shruti ma'am and Netra ma'am, for the excellent discussion that we had. I think it's one of the first times that a webinar has overshot time because of the discussion that were going on. And we look forward to meeting you on the first Saturday of next month. So hope to see you all. Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you, Dr. Deta.
Thank you.
Thank you. Bye.